Hi there, everyone. Good morning. Thanks for joining the round. So today, I'll just be talking about the echocardiographic assessment of prosthetic aortic valves. There's a new guideline that just came out earlier this year in January, the ASC. So that's what we'll be focusing on. My name is Ashwin. I'm one of the Echo Fellows here at St. Mike's. No disclosures. So really the objectives that we're going to try to cover is to, at the end of the talk, develop a comprehensive approach to the echocardiographic assessment of prosthetic aortic valves, particularly focusing on elevated gradients rather than regurgitation, because regurgitation is a complex topic on its own. We'll review the updated guideline, and we'll also discuss some strategies to kind of help figure out what sort of complications might be occurring to the patient and how to assess for those. So on the left is a new guideline. The previous one that we've been using so far has been from 2009. When you compare the two, they're mostly similar, but there are a few changes, and I'll try to highlight some of those changes today. So in general, when we talk about assessing prosthetic aortic valves, or prosthetic valves in general, we want to start with a clinical information. So what's key is to understand the date of implantation, the type and size of the prosthetic valve. The patient's blood pressure is key in when you're assessing aortic valves in particular. Heart rates more so when you're talking about mitral valves. And then having a body surface area assessment, so heart height and weight, because a lot of the important key parameters are indexed. The second part of it is the 2D echo assessment of the valve itself, so directly looking at the valve. And then you move on to the Doppler assessment, which is quite complex. There's a various number of parameters which we'll talk about. And then looking at some secondary echo features like ventricular function, atrial size, RBSP, things like that. And then, of course, comparing to prior studies to see if there's any significant change. So when we talk about clinical information, which is the first step, as I said, the height, weight, and BSA of the patient is key for index values. The type and size of the prosthetic valve and the implantation date are important because it sort of helps you prioritize the complications that are most likely to occur in the patient, and then obviously look for those. So before we dive into too much of the details of the assessment, I just want to quickly talk about the different types. So now there are obviously several different types on the market, both biologic and mechanical. So I'll just go sort of in sequence here from A to H here. The figure A is showing a bileaflet mechanical valve, which is like a St. Jude valve, for example, the most commonly implanted mechanical valve nowadays. B is the monoleaflet mechanical valve, like the Medtronic Hall. C is the old ball and cage type ones that we don't use anymore, the Star Edwards. D is the stented porcine valve, bioprosthetic valve, which is an example would be like a Medtronic mosaic type valve. The E is the stented pericardial tissue valve. Carpentier Magna, for example, is one of those. The F is a stentless porcine valve, like the Freestyle, the Medtronic Freestyle. G is the percutaneous bioprosthetic balloon expandable one, which is commonly one of the brands is the Edwards Sapien one. And then the figure H is showing a self-expandable valve like the core valve. So the reason why this is important, some of these images are just more so for reference, and they're all TEE images. But the reason I put it up is just because depending on the type of valve that you have, there may be physiologic regurgitation, which is normal. So looking at this sort of, let's see if I can get my pointer here. In the second column, this is just an image of diastole, and the third column is systole, and the fourth is just a 3D representation of the valve by TE. The occluder motion is something that you can see quite clearly, sometimes on transthoracic and in TE as well. So knowing that it's a bileaflet valve is helpful because then you can look for the two leaflets. Same goes for the single leaflet valve. And then the ball and cage, you can actually see that shadow moving up and down. The bileaflet valve can have physiologic jets, which are normal, whereas you shouldn't really be seeing large jets like that as much with the single leaflet, particularly if you see it at the annulus. That would be more like a pathologic paravalvular regurgitation. And with the ball and cage, with the movement of the ball, you can sometimes get this artifact or this flow here, and that would be within normal. So knowing the type of valve is helpful to assess what is normal regurgitation and what is not. All right. The same sort of thing goes with prosthetic valves. Although for the most part, if you're seeing regurgitation, particularly coming from the annulus, it pretty much is likely to be pathologic. The only other thing I'll make a comment on in this is that you want to look at the actual, whether the valve itself is well seated or whether it's rocking, because if it's rocking, then that tells you that perhaps there's a gap in that sewing ring or in the annulus, and so that, again, increases the suspicion to look for a paravalvular leak. And then the other reason why it's important to know what kind of valve they have is to understand whether the gradients that they have are within normal or not, and the EOA that you estimate whether that's normal or not. And so there are tables for this, reference values. If you want to look at the most comprehensive list of it, the ASE guideline in the appendix has all of the normal values for all the most commonly implanted valves, various different sizes. I'll just give you an example of the sapien valve here. Depending on the size, there are reference values, and so this is important to be aware of, so that you can compare the numbers that you have with what's available in the appendix to see whether that's pathologic or within normal. The other key point is just not to use the valve size. So if you know that the patient had a 26 millimeter valve implanted, not to use that as the EOA, because when they talk about the size of the valve, depending on the type of valve, they're talking about the outer ring to outer ring size, which is not exactly the EOA. And as you can see here, it's just a pictorial representation of a bioprosthetic valve. The EOA is that internal. The EOA is within the internal diameter, so even the internal diameter would overestimate the EOA. And with the mechanical valve, with a bileaflet, the EOA is what's shown in pink here, divided between the central orifice and the two lateral orifices. So using just the stent size would not be appropriate, and so they obviously recommend against doing that. Okay, so moving on to step 2, which is the echo assessment of the valve itself. When we talk about looking at the valve, there's a few key points. So you want to look at the occluders and the leaflets themselves. It's not always possible with bioprosthetic valves. Mechanical valves are a little bit more straightforward, unless, of course, there's shadowing. Just a point that sometimes, off-axis imaging might be helpful to take a look at those valves, particularly with the 5 chambers and the apical views. The use of biplane or X-plane imaging would be helpful in some cases because you can then reveal the leaflets. Looking at the leaflets themselves, whether they're thicker, whether they're calcified, looking for any abnormal echo densities on the valve that would suggest either a thrombus or endocarditis, things like that. Thickening is quite key because leaflet calcification is one of the most common first signs of malfunction, but also that if you see the thickening in bioprosthetic valves in particular, that should just cue you into maybe increasing the serial follow-up because that might be the first sign of bioprosthetic valve failure. And then the sewing ring, the stent integrity and stability, so that rocking motion should also increase the suspicion that maybe there's something going on, and you want to look for that paravalvular regurgitation to see how bad that is. Mm-hmm. Okay, and when we talk about complications in general, you could divide them into what's called the structural the structural valve itself being affected with in some way or the other, so wear and tear, calcification, the leaflets being disrupted, or fibrosis of the leaflets. In the middle, we talk about what are non-structural. So the valve itself is fine, but it's just malpositioned. It's embolized, like can happen immediately post-op. Pannus formation, which usually takes quite a bit of time and generally starts in the periannular region. Patient prosthesis mismatch, whereby the The EOA of the valve is just too little for the patient's circulatory needs. That's patient prosthesis mismatch, paravalvular regurgitation, and then dilation of the surrounding structures like a pseudoaneurysm after you've implanted the valve, again, increasing the chances of having a paravalvular regurgitation as well. And then the other sort of column, things like endocarditis, hemolysis, which is more common, of course, with mechanical valves, and then thrombosis, thromboembolism is another thing to keep in mind. And when you think about what are kind of like the early complications that are shown here in red, valve malposition can happen early in post-op. Valve embolization, same thing with particularly percutaneously implanted valves. They can embolize, so that could present right away. Usually these things are caught right in the cath lab, and so by the time they show up to the echo lab, we're already aware of it, and we can look for that embolized valve. Patient prosthesis mismatch, though, is one that you don't necessarily always catch in the cath lab, and when they show up and we do a full echo assessment in the first echo, sometimes can have the signs of patient prosthesis mismatch. So you want to kind of look for that. We'll talk about that a little bit later. Okay, so moving on to the Doppler assessment of the valve. So this would be the kind of the bulk of the echocardiographic assessment. When we talk about all the different components of it, the first would be the contour of the jet velocity signal, looking at of course, the peak velocity and the gradients, particularly the mean gradient. Just a point here that sometimes, using a small non-imaging probe can improve the maximum gradient that you observe, because you get in between the rib spaces. So just a plug to try to use that when in doubt. VTI of the jet, so whether you're too far into the LVOT or too far out of the LVOT, that's a key part of the VTI of the jet, and over or underestimation of the gradient. The dimensionless valve index, acceleration time, the acceleration time ratio to the ejection time, which is a new thing in the guideline that they push for. The estimated orifice area indexed and otherwise, and then of course the presence and location and severity of regurgitation. So diving into each of these a little bit more detail. So when we talk about the actual contour itself, this is sort of the first sign that, okay, there might be something going on. When you look on the left side, that's the normal prosthetic jet. So it's triangular in shape, it's early peaking, whereas the obstructed jet tends to be more rounded, more mid-ejection peaking. And that kind of directly correlates with the acceleration time, where in the normal jet, you have a short acceleration time to peak, less than 100 milliseconds is a general accepted cutoff, and then obstructed is usually more than 100 milliseconds. And this is just a real-life example of that. So on the left side, you have what's a normal prosthetic valve with an acceleration time of 58 milliseconds, and that ratio that we'll get into, which is the acceleration time, time from the initial to the peak of the jet divided by the total time of the jet. Ratio of 0.31. The cutoff here in the recommendation guideline is 0.37 for aortic valves. So less than 0.37 would be considered normal. Higher than 0.37 considered abnormal. So on the right side, the obstructed valve acceleration time is over 100 milliseconds, and the ratio is over 0.37. So another helpful parameter is the dimensionless valve index, which is basically a ratio of the VTIs or the velocities across the prosthetic valve. So you're looking at the LVOT in comparison to downstream of the valve in the ascending aorta, and how much what that ratio is. And the generally accepted cutoff for aortic valves is 0.25, less than 0.25 indicating significant stenosis, and more than 0.35 being within normal. And the reason for that is we've had prognostic studies that found that a DVI less than 0.35 is associated with adverse outcomes, but in particular SAVR, not so much TAVI, because that's a little bit more complicated. So the reason why we go with 0.25 and 0.35, that's kind of where it stems from. And then the effective orifice area is also very helpful, particularly because it's less dependent on flow conditions. It's calculated by using the stroke volume and dividing it by the prosthetic aortic valve VTI. just a note here that if you have inaccurate VTIs, or if you have suspicion that your VTIs are challenging to get because of imaging limitations, but you're able to get a really good Simpsons volume, then you can use the Simpsons as well as alternative methods of calculating an EOA. And just a comment again about the LVOT diameter, always use the largest diameter because otherwise you're likely to overestimate. Sorry, if you have an LVOT that's too low, you'd likely overestimate the EOA. Your EOA will be inaccurate. And so, just this is from one of the Jack papers. When we talk about measuring the LVOT, you want to look for the outer edge to outer edge, as shown in Figure A here. Just outside the stent ring, at the bottom of the most proximal aspect of that ring in the LVOT, outer edge to outer edge, and so that you find the most accurate EOA. And in native valves, you tend to go for what is shown here in the bottom, which is the inner edge to inner edge. So it's a little bit different. So just important to keep that in mind. I also want to briefly talk about this concept of pressure recovery. The reason is it's not always very obvious and is important to keep in mind when evaluating patients, particularly with small aortic roots. So the whole idea here is as blood is ejected out of the LV through the valve into the LVOT, the mechanical energy of that contraction is converted into kinetic energy, which is highest at the vena contracta. And following that, when the jet passes the prosthetic valve into the ascending aorta, it slows down, and some of that energy can be recovered into, some of the energy is lost as thermal energy, but some of it can be recovered back into static energy. And when we think about valves in which patients the recovery is the highest, studies have shown that it's the ratio between the EOA and the cross-sectional area of the aorta that best represents the amount of pressure recovery, such that the larger that ratio, the larger the EOA to ascending aortic area ratio, the higher the amount of pressure recovery. So here in this figure, it's just a pictorial representation of two theoretical patients who have the same stroke volume and the same EOA with two different sized aortas. On the left, you have a patient with the aorta that's 2 centimeters in size, and patient 2 has aorta 4 centimeters in size. And so when you look at the actual pressure as it passes across the valve, the pressure in the LVOT drops based on the gradient across the valve, all the way down to, let's say it's about 170 to 145, so about 35 or so. But that gradient is then recovered. Some of that pressure is recovered distal to the prosthetic valve in the patient with the small aorta, whereas in the patient with the large aorta, that pressure is not really recovered to the same extent. And so this becomes really important because when we use Doppler, we're actually just using the fastest jet across across the valve itself. And so when you have pressure recovery in small aortas, we tend to overestimate with Doppler signals, because what we're looking at is this gradient in the middle here with Doppler assessments. But if you took that patient, like patient 1, for example, and put them in the cath lab and invasively measured the pressure in the LVOT with an end-hole catheter and then in the ascending aorta with an end-hole catheter, we find that the actual true gradient, some of it is recovered. So the true gradient in patient 1 is lower in the cath lab than when we figured it out using Doppler echo. I don't know if that makes sense. I hope it does. I hope it did. So why does this discrepancy matter? Well, it's because we want to, when we think about what it is that the patient's heart is hemodynamically doing, we were really looking at assessing the LVOT gradient in relation to the ascending aortic gradient. That gradient is what we find the gold standard is hemodynamic catheter assessment. So we just need to be aware of times where our echo assessments fall apart a little bit, and when we're a little bit underestimating or overestimating the gradient. And so pressure recovery is just something to keep in mind. And when do we need to keep in mind? Well, pressure recovery is most prevalent in patients when, or most, significant when patients have small aortas, and the cutoff is generally as a sinotubular junction less than 3 centimeters, or in patients who have very small bileaflet mechanical valves. And the reason for that is in bioprosthetic valves with small orifices or small aortas, again, that central orifice, you get flow acceleration, and in that small aorta, you have some pressure recovery. So that's the reason for bioprosthetic valves in small aortas. But in bileaflet valve or in mechanical valves, bileaflet mechanical valves, the middle orifice, the central orifice, is very small. And so when you get to your jet velocity, you are most likely to use the peak velocity through that middle jet. But keep in mind that there are lateral jets, lateral orifices that are larger in size. And so when the blood passes past the prosthetic valve, they then combine again from the lateral orifice and the central orifice to form a unified jet. So you actually do get some pressure recovery when the blood joins from the lateral orifice back into the whole aorta. So if you just use the jet from the central orifice, which is what we are most likely to do with a Doppler, then you're likely to overestimate the gradient. So so the two situations to keep pressure recovery in mind is small aortas less than 3 centimeters and small bileaflet mechanical valves. Okay, so just kind of putting it all together in a very quick example here. In the top, you have a normal aortic valve where the acceleration time is 76 milliseconds and the Vmax is 1.8 milliseconds. The bottom one, you have acceleration time over 100 milliseconds and a Vmax that's elevated 4.1 milliseconds. And then just giving you some other information here, the LVOT is the same size. Obviously, the VTIs are different. So when you calculate the DVI in the normal prosthetic valve, the DVI is 0.6, so above that 0.25 cutoff. The DVI in the bottom example is 0.24, so less than the cutoff. And then the estimated orifice area is also lower. And then when you look at the AT over ET, the acceleration time over ejection time ratio, the normal valve in the top is less than that 0.37 cutoff. So is less than 0.37, which is normal. Sorry, that's the top example. And the bottom example, which is the abnormal stenotic prosthetic valve, the AT over ET ratio is over the 0.37 cutoff. So obviously, there's a lot of numbers to remember. So you can just refer to this summary diagram that they have in the ASC guideline, where on the right side, they have all the numbers for that suggest significant stenosis. So we've kind of talked about all of them: the rounded symmetric contour, acceleration time over 100 milliseconds, acceleration time over ejection time over 0.37, peak velocity generally over 4 milliseconds, but even over 3 milliseconds should kind of tip you that there may be something going on. A mean gradient over 35, a DVI less than 0.25, and then an EOA 2 standard deviations below the reference EOA that you can find in the appendix. They have added a extra component here for TAVI valves, which I'm not really going to touch on, but just keep something for you to be aware that for TAVI valves, looking at serial studies and how much the gradient is changing or how much the DVI or EOA is decreasing in serial measurements is important because that percent change can indicate stenosis, and that is in the guideline. All right. Prosthetic regurgitation is kind of a talk in itself. It's a very complex topic, but I just want to bring it up that there is a nice figure in the ASC guideline talking about this. I just cue you into here where these are sort of the summary specific criteria for severe aortic regurgitation, very similar to native valve regurgitation. Vena contracta width, central jet width, large flow convergence, pressure half time less than 200 milliseconds, prominent total diastolic flow reversal, particularly in the descending aorta, and that quantitative measures, when possible, are still very helpful with the same sort of cutoffs. Just keep in mind that when you have prosthetic valves, getting a PISA shell is not always very easy, as you guys know. So it's not always possible to get quantitative measurements, but when available, it's still useful and still representative and accurate. Okay, so what are some of the other echo features? Particularly for aortic valves, you want to think about LV size and function. and stroke volume, because that can affect gradients, of course, and the amount of flow across the valve. LVH is very important. Blood pressure, as we kind of talked about, is helpful and important to keep in mind. Concomitant valvular disease, like mitral valve disease, is helpful to remember, because mitral regurgitation and mitral stenosis can both affect the way the flow across the aortic valve. And then for all patients with prosthetic valves, particularly immediately post-op, you want to think about whether or not the patient has a pericardial effusion. Just something to look for. And then, as pretty obvious, comparing to prior studies is also key. So when we think about all the various causes of an elevated gradient or max velocity, we kind of divide it into various subgroups here. So pathologic valvular obstruction includes things like thrombus, calcification, valve degeneration, the formation of pannus or endocarditis. And then you can also have functional obstruction, which is things like pressure recovery, which we talked about, patient prosthesis mismatch. You can have a high flow state, which could be clinically in situations such as like anemia, sepsis, things like that. Or you can have significant regurgitation, intravalvular and paravalvular, both of which can lead to increased gradients. And then also, when we are assessing these valves, particularly prosthetic valves, where there's a lot of shadowing involved, you may miss the subvalvular and supravalvular membranes and structures. So just always keep in mind that, if the valve looks a certain way, is opening really well, but the gradients you're getting are really high, there seems to be some discrepancy. Maybe we're missing a subvalvular or supravalvular structure that is falsely elevating the gradient, and the gradient that we're measuring is not actually from the valve itself. So just some images here of some of these abnormalities. So when you look at pannus in echo, it's quite echo bright, so echo dense here. It's seen on the left image. This is a St. Jude mechanical valve that has had pannus formation over several months to years. The mass is highly echogenic, and when you then explant it, you can see that that's just formation of this fibrous tissue into the valve. Often the pannus can affect valve motion, but not always. And contrast that with thrombus, often not quite as echo bright. However, in image B here, this is a patient where, I guess in image A on the left, some of it may look somewhat bright. In the bottom image there, that's actually more so shadowing, an artifact from the top annulus. The thrombus is what's shown in the red arrow. One option would be to use echo contrast, and using echo contrast can often delineate thrombi because they end up being quite dark. When you, in opposition to pannus, where the deformity or the abnormality is quite bright. This is just some gradients across the valve showing you an aortic max gradient of 9. This is a TEE image of the same thing. Just trying to point out that sometimes in TEE, the posterior annulus is really well seen, but the anterior annulus has a lot of artifact from the prosthesis itself. So sometimes you can miss the thrombus. So transthoracic and TEE, transthoracic quite good at looking at that, the anterior annulus, and TEE very good at looking at the posterior. So sometimes you need to be using both of them, because in image A, you can see one of the thrombi. In image in the TEE, you can see a different thrombus. But when you actually reconstruct the 3D, and this is where 3D really comes into its own here, when we use 3D to reconstruct the valve, you can actually see two different thrombi. So, and when you measure it on 3D or in TEE, the gradient that they were able to get was much higher than they got in TE. So again, imaging optimization can affect some of that that you can obtain. There's a really nice table in the ESC guideline about this, how to distinguish pannus from thrombus. So in general, pannus tends to form within about after about 1 year's time, and commonly several years after it's been implanted, whereas thrombus can form at any point in the patient's course. Having a look at the patient's INR is helpful, obviously, for thrombus. If they've had sub-therapeutic INRs, that could cue you in that it's more likely a thrombus, whereas there's no connection to pannus. Generally, thrombi tend to happen more commonly in the tricuspid valve, is the most, followed by the mitral and aortic valve. Pannus tends to form most often in the mitral valve in general, rather than the aortic valve. The morphology can also be quite helpful. Pannus tends to be quite small, whereas the thrombus generally is larger in size overall. You can have independent motion of the abnormality, and that generally is more likely to favor thrombus. So if you see something moving quite a lot, they're more likely thrombus than pannus. And if you have mobile elements, again, more likely thrombus than pannus. We've kind of talked about this already, but the echo density is helpful. So thrombus tends to be less echo dense. Pannus tends to be more echo dense, more echo bright. The impact on the disc motion itself is a little bit less clear. I mean, you can have thrombus that, depending on the size, can affect disc motion. Sometimes very small thrombi will not affect disc motion, whereas pannus discs tend to ingrow. And if you definitely have a large pannus, you are likely to see occluder motion. Okay, just to comment about prosthetic aortic valve endocarditis, prevalence is about 1 to 6%. In mechanical valves, the endocarditis tends to originate in the ring itself and then lead to prosthetic valvular leaks and abscess formation, whereas in bioprosthetic valves, for the most part, endocarditis tends to originate in the cusps themselves. Keep in mind with prosthetic valves, you always want to look for, especially if you see a vegetation, you always want to look for paravalvular abscesses, pseudoaneurysms, and fistulas, because they tend to happen much more commonly in prosthetic valve endocarditis than native valve endocarditis. Okay, so now putting it all together, this is an updated figure from the 2024 guideline. It's a little bit different from the 2009 guideline, talking about what to do and how to assess patients who come in with with prosthetic valves that have elevated gradients. So the cutoff that they use here is 3 meters per second. So if you have a prosthetic aortic valve over 3 meters per second, the next thing to look for is the acceleration time and the jet contour. So you look at the shape of the contour and what that acceleration time is. If the acceleration time is less than 100 milliseconds, it's, again, more likely to be normal than abnormal. If it's over 100 milliseconds, cue you into abnormality. Further step that you can introduce now is the acceleration time over ejection time ratio. The number there is 0.37. So it's over 0.37, more likely stenotic, less than 0.37, more within normal. Third step would be to look at the DVI, dimensionless index. Here the number is 0.25 as the cutoff. So if it's less than 0.25, more likely to be stenotic valve. And if it's more than 0.30, more likely normal. After you've done that and you've kind of brought yourself to either normal or stenotic, you may be somewhere in the middle where it could be possible stenosis. There's a few other possibilities to think about. So you want to look at the EOA, indexed EOA, and that's to kind of see if the patient has possibly patient prosthesis mismatch. So let's say they have everything, the valve seems to open normally, the DVI is normal, but the index EOA is very low, less than 0.85, then maybe the reason why the gradients are so high and the velocity is so high is because the valve itself is just too small for the patient. So that's why it's important to look at the index EOA. And then when you're kind of stuck in the middle here with the DVI between 0.25 and 0.29, you want to again look at the LVOT Doppler, make sure that the LVOT Doppler is not too far into the valve or too far out of that LVOT, because either way you may under or overestimate the gradients. And then you also want to look, as I said, for subvalvular structures. Often if the structure is significant, then you should be in this column here, but sometimes you could be in the middle column as well. So this is a nice little figure covering the kind of key aspects of the guideline. So we're just going to delve into some cases here, just to kind of bring everything together and help practice some of these concepts. So the first case is a 25-year-old female with previous mechanical mitral valve, a St. Jude 27-millimeter valve, and has also had a mechanical aortic valve, a St. Jude 19-millimeter valve, due to rheumatic heart disease. Surgery was done abroad. We don't have, all we know is the type and the size. The patient presents with worsening fatigue and exertional shortness of breath, underwent a transthoracic echo. So I'm just going to, just take this out. A second. Okay. Oh, this is the same thing here. Okay, I'll just play that there. I just have to see if I can fix this. Well, no, it was just working fine. So that, let's quickly fix this. Just give me 1 second, guys. I'm just going to see if I can quickly fix that video so it loops. So like reset it each time.
One of the interesting aspects is actually there are more and more things to be measured. But the help is coming because the automated measurements are actually coming everywhere, including all the on-cart system. So all the new echo machines that you buy actually have online measurements, automated measurements, and also offline measurements as well. So, but it's yesterday we had a visitor from Siemens, and we thought that in about 2 years from now, you don't have to do measurements anymore. So that's one of the thoughts. But if you do go to the meetings, like every single company, GE, Philips, Siemens, they all have onboard automated measurements. The question is how accurate it is and what it allows us to actually do remeasurements, and if we have to.
Okay, let's see here if this works.
So hopefully it'll save
nope.
5 to 10 minutes or 5 to 7 minutes of your.
It just has to.
Of every single study.
I don't know why.
I think it just plays with the next one.
Well, you still
Anyway,
have to get really
just
pictures in this
clicking on it. I'll just keep clicking on it in a while, but I'll kind of cover some of the important things. Sorry, I'm not sure what's working.
So Microsoft.
Yeah, it's not entirely clear. But anyway, this is just a transthoracic showing you the view there. This clearly you can see with the color jet that there's flow acceleration across that valve. This is in short axis here. Overall, the leaflets, although a little bit challenging to see, seem to be opening relatively well. And then when you put color on it, there's clearly a lot of flow acceleration across that valve in the short axis everywhere. And this is just a 5-chamber view, again, showing that flow acceleration across the valve. And then the gradient is massive. Just for those, the gradient is about 80 millimeters of mercury, so massive. And I've just, because I suspected I may have some techish stuff, kind of summarized things here so we can all look at it together. So this is just the echo report here. The patient had normal LV size, normal LV systolic function, a well-seated valve, 19 millimeters. Vmax was 5.4 millimeters per second. The mean gradient was 80. The stroke volume around 39 milliliters. Index EOA is 0.3 centimeters squared. The non-index is 0.3. The index is 0.18. The DVI is 0.25, and the acceleration time is 80 milliseconds. The patient only has mild intravalvular prosthetic regurgitation, no paravalvular regurgitation. Again, just to keep in mind always, the regurgitation is important to assess and always think about when you're thinking about innovative gradients. So when you kind of work through the figure here on the right, so Vmax is clearly elevated, the gradient is elevated. The contour, I mean, we can go back and look at it sort of somewhere in the middle, but you can tell from the acceleration time, which is an assessment of that contour, acceleration time is actually not that bad. It's within normal. So you go down to the DVI stage. DVI is sort of borderline, the 0.25, unclear where we are. Could it be stenotic? Could it not be? And then the indexed EOA is very low. So there's clearly something abnormal here. So you just have to wonder, okay, well, could there be something going on? Of course, the patient went on to have a TEE just to see if we're missing anything. Let's see if this one works. This one works a little bit better. That's great. Or maybe not. But either way, it's a little bit longer of a clip. So you can see here, it's a bit difficult to appreciate. But the leaflets do actually open on the left here. Not sure if it's projecting all that well, but leaflets are opening quite well. However, there's clearly a large gradient or large flow acceleration across the valve. And then the same thing is seen here, where you have a lot of flow acceleration, but the valve seems to be opening pretty good. You can see that there's some occluder. I don't know if you guys can see the leaflet occluders on the left image there, opening and closing. Unfortunately, that's not playing very well, but you guys see that opening closing shadow. So leaflets seem to be moving well, and there's clearly still a very large gradient. So kind of going back, and I'll just give you the TEE report as well. Well-seated mechanical valve, the mean gradient was 53. The occluders are moving normally, no obvious thrombus visualized in the valve, but the presence cannot entirely be ruled out. So thinking about putting it all together, what is the most likely mechanism here? I'll just go back to this here. The EOA being so low should always put patient prosthesis mismatch as one of the possibilities, particularly when you have really high prosthetic gradients. The reason why the DVI seems to be a little bit on the lower end when you go back and looked at the actual echo is just because the PW and the VTI were not taken at the most accurate part of the LVOT. So that ratio ended up being a bit abnormal. However, the gradient may have been slightly overestimated, but it's still very, very high. Obviously, a mean gradient of 80 is still significantly elevated. So this patient was suspected to just have patient prosthesis mismatch with normal occluder motion and no actual stenosis of the valve. And then the solution to that would be to explant the valve and implant a larger size valve, which is exactly what they did. So they underwent a redo AVR. And post-redo AVR, the patient had another echo, normal LV function, well-seated valve, this time a 21 millimeter valve rather than the 19. Vmax has now dropped to 1.4 meters a second. Mean gradient is only 6. Index to EOA is 1.1, and the DVI is 0.53. So, and no regurgitation was present. So, just an example of patient prosthesis mismatch, just something to keep in mind, and also to work through when you have discrepancies. Go back and look at the Doppler image and see if the VTIs and the velocities that you're obtaining are accurate, and it's the right part of the LVOT. Just a quick comment about that. So the index EOA, patient prosthesis mismatch refers to when the EOA is too small for the resting needs of the patient. I also want to cue you in. This is something that, as I was reading the new guideline, they kind of make note of. When the patient's BMI is over 30 kilos per meter squared, then you want to use a different cutoff for ppm. So the aortic EOA, generally we are all aware of the 0.65 cutoff, but keep in mind if the patient is obese and with a BMI over 30, then that cutoff is actually a bit lower at 0.55. And again, with patient prosthesis mismatch, you always want to make sure that you're not missing some pathologic reason for why they have elevated gradients. But patient prosthesis mismatch in and of itself is a bad prognostic sign, can lead to reduced survival, increased heart failure hospitalizations, and in time, because the valve is too small for the patient's needs, that large amount of flow through it causes valvular dysfunction as well. If a patient has LV dysfunction, significant LVH, low flow low-grade AS, all of those are bad prognostic signs. Younger age is also a bad prognostic sign when you have patient prosthesis mismatch. We may just have, this is kind of an interesting case, so do we have a few minutes here? Yeah, just a couple, I'll be quick through this. So this is a 30-year-old female with a previous complex mechanical AVR. Unfortunately, we are not aware of the size of the type. It was performed internationally. They presented to their local hospital following a cardiac arrest with VF, and subsequently had a transthoracic echo that showed elevated prosthetic gradients, and they were transferred here for further assessment. Let's see here, the valve, again, seems to be opening quite nicely. If you look at the leaflets, they seem to be opening quite well. And then on the right side with color, again, large flow acceleration across that valve. Short axis, same thing. You have normal leaflet motion, but a large amount of flow acceleration. And then here the gradients, mean gradient of about 40. So elevated gradient, elevated Vmax of 4.01 meters per second. So abnormally functioning mechanical valve with stenosis. Could not fully assess the leaflets. There's some images where the leaflets seem to be working relatively well. Vmax is over 3 meters a second, so over that cutoff. Mean gradient is clearly elevated. DVI seems to be in that stenotic range, less than 0.25. The acceleration time, interestingly, is 110 milliseconds, so kind of not fitting with the stenosis. And indexed EOA seems to be within well, significantly not too bad. It's actually index EOA is clearly very small, so confusing overall when you look at it. So because the visualized leaflets, because the leaflets were not visualized very well in transthoracic echo, the patient went on to have a TEE, where my mouse is sort of just wondering where that. It's kind of right where I want to point. I'm not sure. Is it mouse from our screen? Yeah. I'm not sure. Anyway, the TEE images. If you look at the TEE images closely, the left and the right. I'm sorry that I'm having to loop this again, but the valve does seem to be opening, and when you add color to the right side, the flow convergence seems to actually start ahead of the valve. It seems to be over here. And just use my nasal pointer and show you guys that. Fortunately, is it possible for me to use? I'll just play it multiple times there, but if you look at the flow convergence and where the valve annulus is, the valve annulus is further there, but the flow convergence actually starts a little bit before that. And this flow acceleration right before that. So this is kind of interesting because ultimately with the transesophageal echo, we found that yes, there's a mean gradient that's elevated, but there was actually a subaortic membrane just below the valve, which was not visualized in the transthoracic echo. The membrane was quite thin, 5 millimeters in length and 3 millimeters in width, and encroached very close, very high up into the LV, very close to the prosthetic valve. And because of that, there was significant flow acceleration across the valve with elevated gradients. So this patient went on to have a excision of that subaortic membrane, following which their gradients normalized and the echo findings were within normal. So just kind of bring things back together here, the causes of elevated gradients include pathogenic obstruction like thrombus, calcification, functional obstruction like pressure recovery, patient prosthesis mismatch, high flow state, significant regurgitation, and subvalvular and supravalvular obstruction. Always something to keep in mind that it may, if the valve appears to be opening well, but the gradients are still elevated, always keep in mind there could be a subvalvular or supravalvular structure that we're missing. So some take-home points: use a stepwise approach to assess prosthetic aortic valves. There are reference ranges that are well documented. So anytime you're unsure, just make sure you reference those to see if the reference numbers are within normal. Utilize a comprehensive algorithm that is presented in the 2024 guideline for a stepwise approach. And then anytime there's discrepancy in the findings, transthoracic and transthoracic with the way the valve looks and the gradients that you're observing, always look at other forms of imaging. So TEE could be a very good next step. CT, CMR, particularly when you're looking for pannus, thrombus, things like that. Fluoroscopy, if you're worried about occluder motion and not able to see the occluder as well. So anytime there's diagnostic uncertainty, always refer to some other forms of imaging. And with that, happy to take any questions.
I have a question.
Yeah.
Yeah. Thank you for like regarding assessment of like taking gradients across the study, especially the mechanical valves.
Yeah.
So say we mostly see it like when we have like either bileaflet or tilting or even football cage, we have like lateral flows.
Yeah.
And in the case of like bileaflet, we have even a central jet. Would you suggest like us getting gradients on those lateral jets and the central jet?
So the thing is that when we think about being the most sensitive at picking up stenosis, I think using the central jet is still helpful because that's where the flow acceleration is going to be the highest. It's just important for us to be aware that the central jet is not representative of the full valve itself. So when you have an elevated gradient, I think it may not be as high if you include the lateral orifices, but looking at the lateral orifice will probably end up underestimating the overall jet stenosis too. So I think that we kind of look at, we should still use a central one, I think. It's just to be aware that you're more likely to have pressure recovery and more likely to overestimate the gradient when you have bileaflet valves. I'm not aware, at least when I was looking it up, aware of any recommendations to kind of look at the lateral jet and the central jet and to kind of average the two. If some of the staff who are here on the call have any thoughts on that, I'm happy to hear that. I wasn't able to come across anything like that. They just say still look at the maximum jet across the valve. But I'd be happy to hear any comments about that.
So it's useful to know that for any bileaflet tilting discs that are commonly used in the last 15 years, there are 3 holes in each of these bileaflet tilting discs, and the central hole is the smallest one, would have the highest jet. The challenge is actually isolating them because they shortly come, like the flow actually goes right after. Yeah. So when you put the CW through, basically you look through the whole line. It becomes almost impossible to tell one from the other. I don't know whether you're actually able to identify which hole comes from which in the reality.
I was just going to say, I think it's like a wishful thinking you can get that.
Yeah. The contour is like a mountain. So when you actually do flow studies, the contour is like this, where the central is actually has the highest and 2 are lower. Right. So people have done like flow study within like water tank. And way back when they first came out, and each of them have a unique profile. And when you do the CW, basically just look through everything. So end up actually you capture the whole profile together. And you end up actually a little bit higher, which is fine, but just recognizing that it is a little bit higher, but not that much higher overall. So I mean, it's this prosthetic aortic valve usually is like, to me, over the years, it's a mind puzzling game. You end up actually having to put all these puzzles together, pieces, in terms of like the 2D findings and ejection fraction, stroke volume, and then you have to look at the Doppler findings, and then you do all the calculations, and then you have to integrate all those pieces together to actually figure it out. So, what I find interesting is now they're reintroducing the ejection time, which we know for a long time that could be useful, and the DVI actually putting at a much higher sort of priority. But if you have very high gradient, does it really matter? You still have to do the ejection time and the DVI. Or actually, we do DVI anyway because I believe DVI is much easier than doing the aortic valve area because of the difficulty in measuring the LVOT and prosthetic valve. But is that useful? You have really high gradient, or only in between those between cases?
I think it's just helpful to have more information when you're, especially in situations very unsure. Looking at the contour is very helpful. And I mean, you can kind of get a sense of the acceleration time just with that. But it's pretty easy to check. I don't think it's time consuming to do an acceleration time. Maybe acceleration time over ejection time is a little bit more time consuming. But again, I would save that for when there's discrepant features, when you look at all the different other numbers, the OA and everything seems to not fit, then maybe acceleration time or ejection time might be helpful. Or when the acceleration time is somewhere close to 100 and you're not sure, then maybe having the ratio is helpful. I just think it's another parameter that could be helpful, particularly when you're unclear, when in situations that are challenging.
My question of the ejection time is this. Like we have the profile already, so measuring is not difficult.
Yeah.
Do you know if this is actually in our system that you can actually measure it? Or have we programmed it in?
So it's about that.
I don't think it's in our system.
I don't think it's in our system.
But it's something that we can just do when we're like reporting it, is just to check the exertion time.
You can use the pressure hub, the pulmonic valves for the pulmonary hypertension, just to get the number right.
Oh,
If you
You
want.
could just use, you can measure.
yeah, you can just measure.
Yeah, it's better to just use label measurement, I think.
Yeah, label measurement and just check for time,
yeah.
and then make two measurements, one for the acceleration time and one for the ejection time, and do the math.